Hi, it's my absolute pleasure to introduce our next guest, Dr. Zhi Fong. Dr. Zhi Fong is professor of surgical oncology at Mayo Clinic, Phoenix, Arizona. He's a very well-published author in more than 100 peer-reviewed publications in prominent journals, and he has access to multiple large access database, and he is direct pancreatic cancer database at Mayo Clinic Comprehensive Cancer Center. Thank you, Dr. Fong.
Good afternoon, everyone, and thank you, Arena, and the panel for the invitation, and Jawad as well. We're almost there. 2 more talks before live music and free dinner. And just so I know who's in the crowd, who here is a trainee? And who here is a staff consultant? A consultant. Perfect. Okay, so I'm hoping that my talk is at least a little bit for everyone in a sense where if you're a trainee, it's a little bit of something of how you can maximize your training opportunity to be robotic practice ready by the end of your training. And for the consultants in the group is how you could sell and position your program. So your program is a program for the future that trainees would want to be a part of. And so I want to touch a little bit on the status quo in the US, at least from where I'm from in North America. What makes up robotic training, how to make it work in training, but more importantly, how to make it work transitioning to practice as well. Because I think if you have good training and don't have the right job and the right setting for your first job, it doesn't matter how good your training is, you're not going to be successful. And some of the lessons I have learned from my experience in my first year of being an attending, and some take-home points as well. So status quo in the US, you have heard this already from the previous talks. Most people in North America are not happy with their robotic training, especially in HPB robotics, where they think there are perceived training deficiencies and they do not have adequate access to robot training. An update just recently as well showed that more than 50% of the trainees are just not satisfied. So we are either doing a chronically bad job at robotic HPB training, or trainees will never be happy with their training, no matter what you do. But the light at the end of the tunnel is that this is a paper from Melissa's group as well, looking at the learning curve. But Melissa's group in Chicago and UT Southwestern and UPMC were the pioneers of robotic HPB surgery in North America, where they were the giants that had to climb up and we were standing on their shoulders. So they had to basically learn on the go, and their learning curve for at least a robotic Whipple was 80 cases. But if you were trained in robotics, if you did robotics in residency and fellowship, this is Brian Boone, who's Melissa's resident, who exited fellowship and went straight into robotic HPB practice and did just fine. So his learning curve in practice was 0 because he had good residency and fellowship training and still had good outcomes. So how do you get to where Brian is right now? So first, I think it's important to understand, at least based on my experience, this is what I can perceive as robotic training. I don't do scientific education research like Melissa does, so this is just my experience and you have to take it with a grain of salt, but I conceptualize it as number 1, good patient selection, number 2, knowledge of your anatomy, number 3, knowledge of the operation, which includes knowing the steps and the planes, more importantly. Muscle memory of the robotic mechanics, knowing how to clutch, knowing how to use the third arm, knowing how to bedside, knowing how to space your ports out, ahaptic feedback with no force feedback, at least in the beginning, and your intraoperative judgment as well. And so how do you make it work in training? So I did my residency at Mass General, where it is a maximally invasive program, for better or for worse, right? We have this famous saying, since 1811, unimpeded by progress and innovation. So I had really good open training, where as a chief resident, I had graduated with at least 45 open Whipples, which I thought was a good open experience. But then I did my fellowship. I did do robotic colon cases, and that was a very rudimentary experience for me as a trainee. But then I did my fellowship at Dana-Farber, which is a combined Mass General and Brigham program. And at the Brigham, they did do robotic Whipples at the Brigham, and that's where I got my training, and where I did 18 robotic Whipples in 2 years. But more importantly, I did do 1 month of clinical elective in robotic HPB surgery. And the way that came about was that this is the structure of my fellowship. We had 12 months of clinical surgical oncology. We had a month of medical oncology, radiation oncology, and pathology, 2 months of surgical elective that I did in HPB, but 6 months of research training. And I told my program director 6 months is too little time to do anything meaningful. And if there's anything I can complete in 6 months, it was not worth doing from a research perspective as a fellow. So what I did was that I converted it to a robotic experience as a clinical elective. And at that time, this had just came out where the Dutch was conducting Lay Labs 3, and it's the basically the LearnBot program, where they had a curriculum to go through if you were interested in starting a robotic Whipple program or training in it. They had a curriculum built by Melissa and Herb Zay and the rest of the Pittsburgh group, where you went through at least a simulation curriculum, biotissue drills, watching videos, and proctorship before eventually transitioning to robotic practice. So I had asked Mark Besseling, can I come over to your place for a month and basically do this curriculum? To which he said, sure, before you show up, before you get credentialed at our institution for a month, make sure you watch all these videos. So he gave me a set of videos. As you can see, they're all from simple to advanced cases. Watched this in entirety. It took me about 8 hours, but it was fun watching as well. And then I went to Amsterdam for a month. Spent a month with him, and the first week was nothing but sitting in a simulation. This was my home the first week, and it was nothing but sitting in a simulation lab on modules where there were 37 modules that you needed a score of 95% and above before you quote unquote graduate. It took me 8 hours a day for 5 days to finish all 39 modules and score 95% and above. It sounds simple, but if I was not there for a month by myself, without my family, I would not put in 8 hours a day for 5 consecutive days doing this. How many of you have kids at home? Try telling your spouse that you're going to come into the hospital on the weekend because you need to train on the simulator. It's not happening. The second week was biotissue training, where they were generous enough to provide me with the biotissue materials, where essentially I had to do anastomosis. I did 5 of each anastomosis a day for 5 straight days as well. And by the end of it, I was not allowed to join them in the operating room until I had achieved, based on OSET scoring as well, at least a 90% and above. And once I'm done with that, that's when I was allowed in the operating room. And the other thing that really make it a good experience is that after that, I basically visited most of the institutions throughout the Netherlands. There we go. Sorry. Where I was at VUMC, Erasmus, Leiden, and Enschede, which was also refreshing because they all had tweaked their operations a little bit based on their good and bad experiences and did it a little bit differently and basically took notes. And as soon as I finished observing all of them, I went back to VUMC where I spent most of the time. But beyond that, you don't actually need to be, spending a whole month in Amsterdam like I did. There are a lot of workshops as well that now have cadaveric workshops, so you get hands-on wet lab experiences. You can do them in pigs as well. The Society of Surgical Oncology has a pre-meeting course. ERCAT has one, EMIPS has one. So those are also good opportunities to supplement your skill set. But how do you make it work in transitioning to practice? So when I was in Amsterdam, I was in the midst of negotiating my job. And I feel bad saying this after hearing the availability and access to robot in the UK at least. But Mark had told me when you're negotiating your contract, ask for 3 robot days a week minimum. And I thought he was crazy. I didn't get that. I got 7 robot days a month, which I thought was reasonable, and that's a luxury that I'm privileged to have. But that was the one thing that made it work as well, is that I thought that I needed to be doing a lot, and I cannot just dabble. I can't just be doing 1 robotic Whipple a month because you lose that muscle memory. So the way we made it work when I took my job at Mayo Clinic in Arizona is that for the first 10 cases, we had planned that I was going to be doing a robotic Whipples with one of my senior partners by the bedside. They were not robotic surgeons, they were laparoscopic surgeons, but all you really need is a laparoscopic surgeon by the bedside who knows the planes, knows the anatomy, knows the traction. So we did the first 10 cases as a dual surgeon operation, and we had plenty of divisional support. Like I got 6 to 7 robotic OR days a month, and also the department support as well, where I have never been asked at Mortality and Morbidity Conference by any colleague why I had done the case robotically. It was not a thing of question, and it's a culture thing that was supported by the department. And after that, unfortunately, after about 6 cases, my partners abandoned me, saying that we know you're not a psychopath, we know what you're doing. We just cannot, it's not feasible doing these cases at 2 attendings all the time. We can't align our schedule. We have our cases as well. So after that, I had to learn how to do trainees. But the other thing you've heard throughout the day as well is that you also need a lot of OR support staff, because it's the same set of nurses that does my cases. They know the steps, they know my instruments, they know my bleeding stitch. As you heard this morning as well, you need a hemorrhage contingency plan. For me, it's a 4 proline cut to 8 centimeters. No, I know Ahmad has a bleeding stitch as well. Whatever works for you, you need to have it by the bedside. I have that endo-GIA thin vascular stapler as well. And you need training and QI. And Intuitive is actually very generous with proctorship. If you tell them that you are interested in doing a better job at your cases, and I could help by if you send me to Liverpool and I spend a month and spend 5 days at Liverpool, Intuitive will support the trip and pay for it. So the other thing that helped was that after I had done 6 cases, I thought I knew where I struggled the most at, and I knew my pain points, and I needed to watch how someone else who does a better operation do it again, because then my perspective changes. I'm paying attention to different things, having done a few of my own cases. So try doing a few cases first in your practice, then go out and travel and visit again, and keep doing that as a continuous learning improvement. So from my experience in the first year, I think this has been talked about as well, is that most of us don't have the luxury of being a high volume center with unlimited whipples. Essentially, in my predicament, my options were I either were very selective with picking the easy cases and the unicorns for my robotic whipples, and I only get to do 1 a month. Or I am liberal, where I do almost all my whipples robotically, and I get to do 3 to 4 a month, but they're more difficult cases, but I convert if I don't make any progress. And I decided to choose the latter, and I can go through the data later, but conversion is not a bad word, as Javad was saying. Conversion just means that you have good judgment that you're not making progress, just do it open, which you would have done anyway without a robot. So we adopted that mindset. And block time is critical, and that's not an easy thing to fix in the UK. But if you have an option, you need robotic block time to be able to book these cases. Your group buy-in is crucial, and you need to be monitoring your data. So speaking of data, this was a paper I wrote as a fellow when I was at the Brigham, and I got a lot of flack for being that sensationalistic with that title. I know we talked about a little bit this morning about why you get away with titles, but this made it through the editorial board where I learned that in fellowship, if you combine ERAS with a minimally invasive approach, you get pretty good outcomes. And at least at the Brigham, 40% of patients manage to go home post-operative day 4 or sooner. So I thought, most of them look so great they could go home on day 3. So what we did at Hill Clinic was that I started the program with an ERAS protocol as well. So like I said, we were more liberal with our patient selection. So my first year, we had 64 total whipples. We did 51 robotic, and our conversion rate was 21%, mainly because we were so liberal with our patient selection. But then we had a pathway where my anesthesia colleagues would give a single methadone dose pre-op. We do TAP blocks, no epidurals, no NG tubes, clears on day 1, full liquids on day 2, mechanical soft on day 3. And our outcomes were reasonable in my opinion. Similarly, we get pretty frail patients as well with comorbidities. The median BMI is 30, which is pretty average for an American population. 23% required vessel repair or reconstruction. But if you look at the length of stay, the median length of stay was 5 days. But 47% of patients went home on day 4 or sooner. 37% of patients went home on day 3. This is unpublished yet, and I could hear it from the open group already. Who cares? You have pancreas cancer, you save 1 day, who cares? But in that year, I did 51 robotic whipples. I saved 51 hospital days for the hospital. And I get an email every day from my hospital about the fact that we're at capacity, we're at 115%, there are patients in the hallway, please discharge your patients. I don't kick patients out, it's just that they did not want their blood drawn at 4 a.m. and be seen by me at 6 a.m. They wanted to go home. So at least in our experience, 37% of patients can go home on day 3. Readmission was not any higher, 14% is a reasonable readmission rate, and the major complication rate was 15% essentially. But this data is important because we were tracking our data. I was struggling with delayed gastric emptying and I had no idea how to fix it. But after reflecting a little bit, I realized that we do a stapled gastrojejunectomy, and I put the common anerotomy on the afferent limb, and I realized that was stricturing and narrowing the efferent limb, and that was stricturing and narrowing the efferent outflow. So when I flipped my GJ and I stapled it, and the common anerotomy was on the afferent limb, suddenly my BGA rates went down. So it wasn't really delayed gastric emptying, more that my common anerotomy was stricturing on the efferent limb, and I placed the common anerotomy there. So who here knows who this guy is and what was about to happen in that scenario? Yes, this is Mario Götze, World Cup 2014 finals. He was substituted in against Argentina at the 87th minute, and he scored the winning goal that sent Argentina home and won Germany the World Cup championship. And the reason I put it up here is because when I did my first robotic Whipple as a faculty member at Mayo Clinic in November 2023 on a Monday, Tuesday, my trainee asked me, when did you do your first robotic Whipple skin to skin? I said yesterday, right? And my point being is that as a trainee, you keep thinking that you needed to do everything from start to end to be able to do it. But the reality is that no consultant, no attending would be comfortable enough letting you do the uncinate dissection robotically, no matter how good you are. But the key to this is that you have seen this 1,000 times and you stay ready. And when it's your turn, you will be ready. In this case, he had been watching the game for 87 freaking minutes, right? His first kick was the winning goal, right? So my point being that I think for the trainees in the crowd, don't sweat the details. You do not need to do everything from start to end. Sometimes it's just not reasonable to expect your attending to let you do everything from start to finish. But if you pay attention and stay ready, you will be ready. So this is how it all comes together. It covers everything that we just talked about, but I just, in the sake of interest, go straight to this. It is the future. So a few hospital systems in the US are already working on this, where Advent Health, for example, has 11 hospitals in the US. They are all credentialed under, all surgeons are credentialed under the same health system. But they're thinking, I shouldn't need 11 robotic surgeons in 11 hospitals to do these operations. What if I only had 3 surgeons who knew how to do robotic HPB, service all 11 hospitals, and essentially, this is...
Imagine you're at home, okay, and you get called, or you're on the road, okay? I'm going to pull out my portable console. Just it's all here, okay? Okay. Don't imagine that it's going to be some giant console sitting in your home. This is a console that could adapt to 8 different hand pieces that exist in 8 different robots at present, okay? And that's Paolo Fiorini, who's sitting in the back there smiling. And again.
Anyway, interest of time, there was a video by Zhi Ven Fong. He's not my dad. But we are closer than you think it is. People have already laid down the fiber optic, wires in the ground. It's coming. If you're not positioned well to be doing robotic surgery in the future, a surgeon doesn't even need to be hired in your hospital to be doing your cases in the next 10 years. So I do think that it's important to make sure that you're trained in robotics if you're going to be a surgeon whose peak career is going to be the next 20 and 30 years. And for the programs, I do think it's important to make sure that we're positioning our trainee well to be in that position as well. Thank you.
If it goes wrong and you get torrential bleeding and the specialist is miles away and you need to convert?
It's a good question, and I want to caveat with the fact that I'm not involved in the development. So I'm like, but from listening to people who are involved in development and what their response is that I think it can take in many shapes or form. So let's say if you're taking what UMan usually uses as an example is that if let's say this is completely hypothetical, but if let's say Liverpool only does total nephrectomies, and let's say Richard does partial nephrectomies for the cancer. It could be that you have a surgeon who knows how to do a total nephrectomy as a backup, and Richard tries to do a partial nephrectomy from afar. And if the partial nephrectomy doesn't work out, your worst case scenario is a total nephrectomy, which you were going to do anyway. So similarly, if Iswanto can do a robotic right hepatectomy and I cannot, and he's doing it from Tampa on my patient in Arizona, and if it doesn't work out and he gets into bleeding, the worst case scenario is that I'm there, I open, I complete it, and I do an open right hepatectomy. So the worst case scenario is that the fallback is always your default anyway, and you try to get as much advantage as you can. We're not saying that we're going to do a robotic right hepatectomy in a scenario where you don't even have a general surgeon who knows how to open the belly, so to speak. So it's a graduated improvement, so to speak.